Thank you very much, Greg. It wasn't that snarky at all, actually. I'm surprised. You caught me off guard, being so nice. I think I will dim the lights a bit because now it's after lunch. You will start to get sleepy and bored. So we can maybe go a bit down because the images I'm about to show you look much nicer if it's dark. So yeah, right. The first one who is snoring, I will. Now, imaging, actually really, nearly 20 years ago, I started to do research in imaging. And as Greg said, I mean, I tried to submit papers. I tried to submit abstracts to scientific meetings. No one was interested whatsoever. So that was a bit disappointing, but I'm a bit, I'm a bit stubborn. And so I stuck with the topic, and now people are really interested in it. And I try to convince you that it's really relevant, and that again you have an impact on what you. We actually in the break we were discussing what is good, what do we need. Of course, we have financial restrictions. If it came to me, you would kind of get every imaging every time you come to me, but it's not about me. So I try to figure out what is a good way that we can afford. Imaging, we cannot afford everything, but I will try to show you what is going on, what we can learn from your disease without any pain actually involved. Only sometimes you need a needle to get a contrast agent, but most of the time it's non-invasive, as we say, and I think that's a great benefit for imaging. General information, we talked about the garden and the weed. And I love this image, and this is kind of showing it on another level, showing it that you know your disease is growing in the bone marrow, the red stuff, and the bone marrow is, as the name suggests, within the bone. So you have your bone, and you have your kind of the stabilizing part of your skeleton, and in there, protected by the bone, there's the bone marrow. This is very important because in myeloma, the actual disease is growing in the bone marrow, and a lot of people mix that up, even doctors. Maybe not even doctors, but doctors. And but the effect, the most impressive effect, as you know, fractures, osteolytic lesions, osteoporosis, that is happening in the bone. So there's not really a strong connection there, but they are kind of, bone is not, that's also very important, bone is not a dead tissue. Bone is recovering, and we discussed that when we talked about the bisphosphonates. And bone is recovering, it takes very long, and the older we get, the longer it takes. But bone is growing, bone is a vital kind of organ or tissue. So the bone and the bone marrow interact, but they are not the same. Bone marrow is not bone. Bone marrow is the organ where our blood is formed, and the bone is the skeleton that keeps us upright. So when we look into which imaging techniques are out there, those are the most common ones. There are more, but they are not that relevant for myeloma. Those are the relevant ones for myeloma. And if you look into that, you will see different information if you use a different technique. Oftentimes I get asked, because especially for financial reasons, why do we need all these different imaging techniques? Can we just use the best and then use that forever? The problem is there is not the best, because the best for the bone might be something different than the best for the bone marrow. And I will come back to that later. So X-ray and computed tomography, which is basically just a further development of X-ray, are the bone detecting or the bone imaging techniques. And the CT part is, the CT is when you use an X-ray, and usually X-ray you just have kind of the source of your X-ray, and the beam goes through your body, and on the other side you have, in the early days you had a film, now you have a digital detector. And with a CT you have the same concept, but it is moving. So you take pictures from every angle. So CT, different angles, X-ray, just one, or most of the time one, and then another one, also go into that. Then you have the bone marrow imaging techniques, which is basically also to a certain degree the CT, but much more the MRI and the PET, positron emission tomography. MRI meaning magnetic resonance imaging, and I will come back to those techniques and explain them more in more detail. As you can see here, PET usually is not used alone. So you have the bone marrow information, but it's often, most of the time, it's combined with the CT, and I mentioned CT here. CT is the bone information. So PET-CT seems to be quite good because it combines bone and bone marrow. And then we also have some so-called functional information, meaning that we get information about processes, mechanisms that are going on in the bone and in the bone marrow. And this is what's also very helpful, and there are some techniques giving us more insight than just the morphological changes, just what we can see, but also processes that are going on over time. So this is very, very neat, and I will elucidate to that later on. Starting with X-ray, because it's the most common one, it's the cheapest one, it's the oldest one. It has the advantage that it's nearly everywhere available. I gave these talks in Europe, in Western, Eastern Europe, in Asia, and X-ray is nearly everywhere. So you can use it, and we just rewrote the guidelines to adjust them to the guidelines about imaging, to adjust them to what we have now compared to what we had 10 years ago, where the last guidelines were written. And the colleagues from other countries asked me to keep the X-ray in because all over the world it's much more common. And I was surprised when I came here, and I was not that surprised because I talked to colleagues before, but I was surprised that at Roswell, when I came here, X-ray was the standard imaging technique. And now my colleagues, and most of you know my colleagues, they're very happy that I could show them that we have better things than just X-ray. It's the basis of our old staging systems. You might have seen Jury-Salmon or DS staging system in your notes. And for the CRAB criteria, C meaning hypercalcemia, R renal damage, A anemia, and B is the bone disease. And when that was published in 2003, the basis was the skeletal survey. So it has some history, but I will let you know why I think it's kind of nowadays it's rather obsolete. It has a rather low radiation dose. I earlier said that when in the early days when Konrad Röntgen in, I think, Würzburg, right? See, in his beautiful city, second best city in Germany. Then when he did his first imaging stuff, he used really films like the old films, you know, from cameras. Most of the people here do really know what I'm talking about. And they used a lot of radiation. Nowadays, we don't need that high radiation doses anymore because the detectors that are taking off this information are much more sensitive than a regular film. Disadvantage is it has a rather low sensitivity, and I will show an image proving that. And we know that for a long time, but for a long time we also did not have an alternative to that. It is a rather long examination time. I guess most of you had a skeletal survey. I mean, you have to move your limbs, and if you have back pain already, then it's not nice to do that. It's not very comfortable compared to other techniques we have nowadays. And this is a study that was done even before I was born. And so we have this knowledge for a long time, but we still had no opportunity to change that. They drilled holes in the bone of a corpse, and then they did an X-ray. And you can see here, they filled it with water because water is somewhat similar to a tumor growing in there. Tumors have a lot of cells and are very well have strong circulation, so they are kind of like water. And so they filled it with water, and then they did an X-ray. And then they drilled it, made it a bit bigger, filled it, X-ray, and so on. And they saw that they have to destroy 30 to 50% of bone until you see anything at X-ray. 30 to 50%. That is, in my opinion, and maybe you disagree, but that's far too much. We cannot wait until 30 to 50% of the bone is destroyed until we see anything at all. Therefore, CT. I am already promoting CT. I am not paid by any CT vendor whatsoever. This is just my personal opinion and the experience I have developed over the years. CT, as I mentioned, the X-ray machine going around your body looking from every angle. So you have kind of a 3D information about your skeleton. Advantage, it is definitely superior, and we have done an analysis worldwide. We collected patients. It was not too many, but we had like we started with 200 and something patients all over the world, where a CT and an X-ray was done at the same time point. And we compared that, and we found that in 25% of X-ray negative patients, CT was positive. So those patients would have been missed if a CT would not have been done. So that is very relevant, I think 25% more with a CT. So we have really a number to prove that CT is better than X-ray. We have so-called Lowdose protocols, and just last week I received an email from our radiology department that they have the software now. It's just a change of software. You can use every CT scanner, at least a bit more modern ones, and you can use a so-called Lowdose protocol with a lower radiation dose. Because CT, it takes a bit longer to take the images, not the whole examination, but you have a bit more radiation exposure, but you get this much more information. And as I mentioned, Lowdose protocols have a lower dose than a regular CT you would do in another cancer patient. For myeloma, we are mainly interested in the bones for this. And for the bones, because they are very dense, as you know, you don't need a very high dose. And that's something that's very relevant so that we can use those Lowdose protocols. As I mentioned several times now, 3D information, because we look from every angle, which is very important, especially for the spine, because the spine is the part of our skeleton that keeps us upright. And as you know, if you had a fracture in your spine, that is really bad. And we get information from every angle, so we know where the fracture was. Not only that the vertebral body is lower, but where it is lower and how it behaved, and where are potential osteolytic lesions that might cause further fractures. It's rather convenient because you just have lie flat on your back, go into the machine, go out again. It's not the long tube as the MRI, it's a kind of just this ring. And you go in and you go out, it takes about three minutes. So that's much more convenient than a conventional X-ray as well. It was included in the new definition, and I had a lot of discussions with colleagues when I was rather early convinced that that CT is better than X-ray. But colleagues said, yeah, but then we will see so much more. And I said, that's your argument? You don't want to see that much more? And in the end, most colleagues are really convinced now that seeing more, knowing more about the patient, especially about the bones, is really relevant. I was surprised that people really asked that question. And it came not more than once. So it is of prognostic significance. We know more bone disease on the long run can have an adverse prognostic effect. It's not that strong as fish and the other stuff, but we found that there can be some information on prognosis. It doesn't change treatment, same as with, to a certain degree with fish. It has a bit higher radiation dose, as I mentioned. It takes a bit more radiation to get this 3D information. So it's about 2 times a skeletal survey. But as you know, most of you in the past, hopefully not that much today anymore, had X-ray every year because the sensitivity is so low. You have to do it every year because if you want to see a change that is 30 to 50% already, you have to do it more often. And my experience, we had the privilege in Germany that we could use CT for, I think we started in 2006. So we had it for over 10 years. We found out we don't need the yearly imaging, because if the CT is negative or if we see there's stability and there's no progression in the serological markers, then there is no very, very low risk indeed to develop bone disease. So because of the higher sensitivity, we can do it less often, and then we kind of actually save radiation dose. It is a bit lower sensitive for the plasma cell infiltration because, as I mentioned, that is especially for the bone. The CT part is very good. For the bone marrow, the other techniques I will talk about now are more sensitive. So we still don't know which one is the best and which is the best combination, but we know that for the bone, the CT is the best. This is how a so-called Lowdose CT looks like. We get this 3D information. This is a myeloma patient. You can see here we kind of fly through the body. We get also additional information. We see how the lungs are, if the heart is bigger or smaller, if there's something going on. It's not perfect because we use this lower radiation dose that gives us a bit lower sensitivity, but you can see here we can very nicely see the bones. We see how strong the bones are, and depending on the height of the patient, we can go pretty far down to get this whole information on the whole skeleton. This is the mentioned study. We compared CT positive, skeletal survey negative, and we found 25% more sensitivity in the CT part. We looked where are the osteolytic lesions, because that's something that's not, to a certain degree it is relevant, because osteolytic lesion, even though it's frightening to have an osteolytic lesion in the skull, it doesn't really matter for you because it does not hurt you, it does not grow into the brain, which some people are concerned, and I understand this concern, but it's not really happening. So about 10% of patients had skull lesions. The most of the patients have their lesions in the spine and the pelvis, where it's very relevant because it's causing instability in the worst case. So this is very relevant. The theory behind that is that because in the spine and in the pelvis, we as adults have most of our blood-forming bone marrow, and this is a very nice environment, not only for our blood-forming cells, but also for our myeloma cells. So they get all the nutrition they need. It's highly perfused. We have a lot of blood vessels there, and so the nutrition comes there, the oxygen comes there, so the plasma cells love it, and that's one theory why most of the osteolytic lesions are actually in the spine and the pelvis. And this is something, as you can see here with my very limited, more than limited artist skills, that the spine and the pelvis are the most important ones. And if your doctor says, okay, I'm sorry, I cannot do a whole body imaging, I can do a spine and the pelvis, this is already very good because it covers most of the osteolytic lesions, and also the most clinically relevant ones. Coming to MRI, magnetic resonance imaging, not radiation-based like skeletal survey, conventional X-ray and CT, but magnetism-based. I'm not a physicist, but to me it was explained that you put energy with a magnetic field into a system, in this case our body, that consists mostly of water, as you know, and you put energy into the water, and the water molecules and the electrons get to a higher level of energy, and then you turn off this magnetic field, and then they fall back, and you can see the energy coming out of the body, and then you can measure where is a lot of energy coming from, where is less energy coming from, and that's kind of very, very easy, as far as I understand, a very easy way to understand how magnetic resonance imaging works. And until now, when it is used for over 30 years now, until now there's no sign that there's any negative effect on us by this technique. So that's very nice, because all radiation, of course, has this slightly increased risk to also put damage to our body. Advantages: it shows infiltration of the bone marrow before the actual bone is destroyed. I said in the CT, you see those osteolytic lesions with very high sensitivity, and it's a very good technique to measure that. But in the MRI and also in the PET, and I come to that later, you see the infiltration of the bone marrow before the bone is destroyed. And this is very nice because it gives us a higher sensitivity. We see changes before the actual symptom, the osteolytic lesion, happens. This is very important. It has a very high resolution also for soft tissue, and the bone marrow is kind of a soft tissue. That's very valuable, and even if you don't use contrast agents, you have a very high sensitivity to see changes also in the soft tissue organs. Not that much in the lung, because we cannot hold our breath for half an hour, because that's how long, or even longer sometimes, an MRI takes. So the movement is a problem. Since the CT is only a few seconds, you can hold your breath. But with the MRI, you cannot hold your breath, so the lungs are not very well displayed. But that's not a big problem, because myeloma is very, very rarely in the lungs. You can, to a certain degree, differentiate between a fracture you have because you might have some years on your life clock, meaning you're a bit older, and you have an osteoporosis, which occurs in our lifetime. So it's a benign fracture versus a malignant fracture caused by multiple myeloma, because we see if there are a lot of cells or if there is a lot of fat. And fat is what's usually in our bone marrow when we become older. But if you have an infiltration by multiple myeloma, then there's a lot of cells, and the MRI can, to a certain degree, differentiate between a lot of cells versus a lot of fat. Fat would be benign, cells would be obviously myeloma and malignant. It is relevant for follow-up. When we see those changes in the bone marrow, we can see how they grow or disappear, which is better, of course, after therapy. So that helps us to get more information. It is now part of the new definition of myeloma. So we decided as a myeloma community, we don't want to wait. If we have the chance, we don't want to wait until the bone is destroyed. We want to see the early changes, and even those early changes might trigger the initiation of systemic treatment. Disadvantage, it is not as good as CT for the bone. So until now you could have said, okay, MRI is the best, and to a certain degree I feel like that, but the problem is you don't see the bone itself. If a tumor out of the bone marrow grows very large, then of course the bone around that is also destroyed. But if you only see a change in the bone marrow, you don't know if there's also an osteolytic lesion or not. And some patients cannot have an MRI because of this strong magnetic field. If you have a pacemaker, for example, oftentimes you cannot use an MRI in a patient, but it's rather rare. PET-CT, as I mentioned, combination of PET and CT. It's only mentioning PET, but usually we do it with a CT. The PET part, positron emission tomography, is you infuse a radioactive tracer, which is a very short half-life, so it's not dangerous for you. You give a tracer in the vein, and then it distributes in the body. And this tracer is a nucleotide that is emitting radiation, and it's attached to a sugar. And the cells in our body that use a lot of sugar are, for example, the brain cells. Actually, it's not shown here, but usually the brain lights up very well. The brain cells, cancer cells, inflammatory cells. So there is where you see the tracer. And so we know where the inflammation usually is, like in the teeth, oftentimes there's something lighting up, or in the lymph nodes if you have a cold. But we know that, we also know that the brain has a lot of sugar uptake. But other than that, if something appears on the PET, then we know, okay, there might be malignant cells. And this is pretty sensitive and pretty well established. So, it shows us the metabolism. So high metabolism is a very strong signal for cancer cells. It is of prognostic significance. If you have a lot of those cancer cells in your body, it's worse, of course. It shows disease activity together, this combination of tumor mass and proliferative metabolism activity. The negative, the disadvantages are that you can have false positive results. As I mentioned, you can have an inflammation somewhere and you don't know if this now, is it inflammation or is it tumor? But as I mentioned, since we know where the inflammations usually are, most of the time we can differentiate. In the worst case, we have to stick a needle in there to see if it's really myeloma or if it's just an inflammation. The radiation dose is of course a bit higher because you add the nuclear tracer, which still has a low radiation dose, but it's not zero, to the actual CT, where that also has some radiation exposure. So this combination has a bit higher radiation, but again, the information we gain from that is so valuable that I think it's really worth taking this very, very, very tiny risk of getting a cancer from radiation exposure. So coming from MRI, as I mentioned, we can have small tumors of myeloma growing in your bone. And this is very interesting, and it's not known for a very long time. We know that myeloma can infiltrate the bone marrow, and you can see here the darker part is infiltration, and you can see here this is rather homogeneous and diffuse infiltrated. That's what we expect from a hematological disease, because we would expect that the cells are all over the place because they are the immune system, and the immune system has to be everywhere in our body. So this is a myeloma patient with a diffuse infiltration, and this is a myeloma patient. From the outside they look pretty similar, of course not, but you know what I mean. And here is a normal bone marrow of an elderly person with a lot of fat. You can see here the fat, the subcutaneous fat, and then you can see here this is kind of also a lighter gray scale. They call it, the radiologists call it hyperintense. But then you can see those darker spots or hypointense spots. Those are myeloma infiltrations. We don't know if they are really osteolytic lesion. It can be, but it does not have to be. We have patients where we see those focal accumulations before the actual osteolytic lesion has happened. So now if we know about those focal lesions, then we can start treatment, either local or a systemic treatment. So some patients have a diffuse infiltration, some have a focal infiltration, some have both. So that's something that we have to keep in mind. It seems to be prognostically relevant, also a very old publication, but a normal looking bone marrow, which still can have myeloma in it, has a pretty good prognosis. This is the old days without our new fancy treatment, but basically it shows you that there seems to be a biological difference between this nodular infiltration and the diffuse infiltration, and we are just in the process of learning what that really means. Does it, or what does it do to our treatment indication? Should we treat a patient with those focal lesions without osteolytic lesions, or should we not? Here's a patient of mine back from Germany, and as I mentioned, we had X-ray. We had CT rather early there, and we had MRI. And we looked in this patient. We did an examination because he had a smoldering multiple myeloma. We knew there is some myeloma, but he had no symptoms. He was feeling great. And so we did our imaging just to work him up, and we said, okay, this looks normal. Then we did another imaging like 6 months later, and suddenly we saw this spot here. And we said, that doesn't look like it's belonging there. So we did, you see that. So we went back in his imaging and saw 6 months earlier, there's this tiny spot. And actually at that time we said it's negative. But knowing where we had to look, and this is a hip of the patient, we saw, okay, there was something. And we saw that within 6 months it was growing. Something growing in your body if you're not pregnant is usually not good, right? So in this case, it really was a myeloma because he was a man. So we were pretty sure it has nothing to do with pregnancy. Sorry, bad joke. And then we went on and did a CT because we wanted to know if there's any change in the bone. And actually, you can see here there's the osteolytic lesion correlated to this focal lesion that developed over time. And one message I want to mention, those focal lesions, they can be misleading, especially if a radiologist is not used to see myeloma patients. They oftentimes send us patients with could be myeloma or suspicious of myeloma, and oftentimes it's nothing. It's a hemangioma that never hurt anybody. But you have to be careful, and if we are in doubt, we usually just do another imaging to see if there's any dynamic. If it stays the same, not a big issue. If it grows, you know, that's not good usually. And we looked into those focal lesions, and as I mentioned, we kind of predict the development of a bone disease. And of course, a lot of you have been diagnosed with full-blown multiple myeloma, but if we have a smoldering myeloma, or if you have an MGUS, and we find those changes, then we have to respond and to see if those changes change over time, and that would be a trigger to treat a patient. And this is actually what I wanted to show you, but I already talked about that, so you don't have to see another Kaplan-Meier plot, even though Dr. McCarthy explained to you what a Kaplan-Meier plot is. Interestingly enough, when we saw patients with growing focal lesions or developing new focal lesions in the bone marrow, nearly all of them, you can see those small Bs, and these Bs are from the CREB criteria, the B of bone disease, and you can see here most of those patients actually really developed bone disease later on, and bone disease was the reason why they were treated later on, giving us this information that we can see, or we can to a certain degree predict the bone disease, which of course is very clinically relevant. This is what I mentioned, that we can to a certain degree differentiate an osteoporotic fracture without any malignancy versus a myeloma fracture. Again, a lot of colleagues send us patients, and I'm very happy that they send us the patients because then we can work it up. But we can see that a fracture caused by myeloma looks different from a fracture that's caused by osteoporosis. So MRI in this case helps us with that. Treatment monitoring, usually you know where you measure your free light chains, your M spike in the blood and in the urine, but we can also gain information from imaging. And this is a very nice information I want to give to you. When I started treating myeloma patients, I was told osteolytic lesions of myeloma patients never go away. It's a scar in the bone, there's no healing. Then we started to use more sensitive techniques like CT, and we saw that, and actually we did an analysis of patients, and we saw that about 75% of patients showed some kind of positive change over time. Together with our current treatment, together with high-dose chemotherapy and bisphosphonates, we saw that in 75%, not tremendously, but in 75% of patients, we saw positive changes, and maybe we would see it even more in patients when we do further CTs along the line. So this is a very positive thing we learned from imaging, that you can see here there is kind of a bone healing. This is an osteolytic lesion before treatment, and this you can see this whitish that looks like to a certain degree like the rest of the bone. There the body starts to heal this osteolytic lesion. You can see this is a rather big one, so it's not easy for the body to heal the whole osteolytic lesion, but it increases the stability in this area. And there are some things we can do to improve that, and I think exercise in the right dose and in the right setting can be something that promotes this kind of bone healing. We see this, focal lesions. This is a part of infiltrated bone here and here in two different sequences of the same MRI. And you can see here this darker gray scale here is smaller. So we see the shrinking of the tumor over time. Same here. And we saw that if you have no lesions left after therapy, and the same is true for PET, this is MRI, if the lytic, not the lytic lesions, if the focal lesions, the infiltration of the bone marrow goes away over time, this is very good for you, of course. If you have a lot of them left, we might consider changing treatment or adding something to the treatment because you still have too much myeloma in you. You have heard a bit about MRD measurement, it's minimal residual disease. You have heard it's very important that this is as low as possible. That the response to treatment should be as good as possible. The problem is when we are negative with our free light chains, negative with the immunofixation, negative in the urine, we still can have some disease in the bone marrow, and then we do bone marrow biopsy here, which is the easiest way to get it. But the problem is that in a French trial that was mentioned several times now, they found that you can be PET negative, PET or MRI, either one, negative and MRD positive. So you can stick a needle here, PET is overall negative, and you think, okay, great. Then you stick a needle in here and you're still MRD positive. Or you can be MRD negative, you stick a needle in here, but you have something growing here. So it's very important to have the whole picture, and whole picture meaning as much of the body to image as you can, plus doing this very sensitive technique with the bone marrow. That's also a question oftentimes coming from patients. Since we have these very sensitive and great imaging techniques, do we really still need bone marrow? The bad news is yes. At the moment we still need it because we have to see how many of the patients, the sensitivity of the bone marrow biopsy is still much higher than our imaging techniques. But we are getting there. And I didn't promise you that we can get rid of bone marrow, so don't get me wrong. So this is kind of demonstrating that. You can see again this dark spot, which is a myeloma lesion. If you put in a needle here, it might be MRD positive. If you put it in this lighter gray spot, it might be negative. So again, I think it's very important to do imaging plus MRD assessment plus our serum and urine analysis. And this is showing if both is negative, MRD is negative and imaging is negative, then the prognosis is very good. So, and that's what we are going for, not with any means, because sometimes patients just stay in a low tumor burden, but we try to bring most of you in as deep as response as possible. So research, just briefly, what are we doing to learn more about the imaging techniques? We can combine PET and MRI. We cannot do it here yet, but there are machines around the country where we can do that. At the moment, the benefit over a PET CT is not that much, so this is just future. We can use new functional techniques where we can actually measure how many cells you have in the bone marrow, not only count them under the microscope, but also can measure them in X-ray. And this is again based on the water content, as I mentioned. If you have a lot of cells, your water molecules cannot move that far. If you have less cells in your bone marrow, they can move further, and the machine can measure that, so-called DWI, and it's fancy looking here, as you can see here, those white spots were myeloma infiltrations, and this is a patient in CR. You can see much fewer white spots, but still some left. So we get information this patient is in CR, but we still have a few myeloma areas left. So this is something where the imaging really gives us more information. And we use computers, and Jenny was talking about big data. We try to teach our computers to learn to help us analyze images, because I can tell you a whole body Lowdose CT, a whole body PET, and a whole body MRI, each one has about 2,000 images. And our radiologists have a new diagnosis. They have the scrolling finger, because on the computer they have to scroll through. And this we try to teach our computers to help us to identify those focal lesions in the body. To summarize, when do we need which information? In MGAS, we want to be sure that the patient has no osteolytic lesions, meaning you don't have a multiple myeloma. In smoldering myeloma, the same. We also want to rule out that you have this kind of pre-existing condition with these focal lesions in the bone marrow that might eventually develop into osteolytic lesions. In newly diagnosed multiple myeloma, you have to exclude you have to see where osteolytic lesions might be. You can look into the tumor mass, how many of those focal lesions are there, how stable is the skeleton. Is there cord compression, the spinal cord, where the nerves go from the brain to the extremities? Is this compromised in any way? Do you have any soft tissue accumulations of plasma cells? And in the relapse disease, when a disease comes back after treatment, you also want to see, have the osteolytic lesions grown or are there new ones? Again, the stability is important, cord compression, soft tissue tumors. This is what we want to know. What can we use? The CT and the MRI give us good sensitive information to rule out myeloma if a patient has an MGAS. In smoldering myeloma, basically the same, but sometimes we use a PET CT if we have focal lesions to see if they're really active or if it's just accumulation of something else. In newly diagnosed myeloma, of course, the osteolytic lesion, we want to know if there's any instability. So the CT part of a PET CT is very helpful, and the PET gives us even more information on the activity of the disease. And in the relapsed refractory disease, because the tumor burden is lower, because we already know that you have a myeloma, oftentimes an MRI is beneficial, or sometimes a PET CT to differentiate between activity of focal lesions and inactive lesions. And with this, I would like to thank you, and I think we have later a roundtable where we can discuss questions for that.